Head-up tilt test, also known in short as HUTT, is done for the evaluation of recurrent syncope with no evident cause. Suppose there is severe aortic stenosis, then you know that the evident cause is aortic stenosis. Then you will not go for a HUTT testing. Change in heart rate and blood pressure on assuming the erect posture. It's exactly not erect posture. Initially the tilt is given as 70 degrees, is evaluated during HUTT. It is also useful for evaluating POTS, known as postural orthostatic tachycardia. There will be tachycardia only without hypotension, unlike in usual syncope. There are different protocols being followed in different institutions. Whichever be the protocol being followed, certain things are common. One, you have to strap the person to the tilt table. Otherwise, if syncope occurs, the person can fall down and cause injuries. Secondly, monitoring, hemodynamic monitoring is required. You will connect pulse oximetry and blood pressure monitoring. In some places they do invasive monitoring with intra-arterial blood pressure monitoring. That may not be ideal because that's an invasive procedure which can itself induce a syncope. Ideally, you need beat-to-beat finger blood pressure monitoring, but the device is mostly not available and fairly costly as well. The reason is that when there is a syncope, it is difficult to check the actual blood pressure fall. You can only check after the event and before the event. So ideal is to have beat-to-beat finger blood pressure monitoring. In any case, there should be resuscitation tray and personnel available at hand because syncope can sometimes be prolonged. Then you need all the supportive measures to be given in case of syncope. Indications for HUTT will include recurrent syncope or pre-syncope, high-risk patients with single syncopal episode like serious injury with syncope while driving, no other cause for symptoms by history, examination or cardiovascular and neurological workup, elderly persons with recurrent unexplained falls. Then it could be done for the differential diagnosis of convulsive syncope, orthostatic hypotension, postural orthostatic tachycardia syndrome as mentioned initially, psychogenic syncope, hyperventilation syncope, and carotid sinus hypersensitivity. Coming to relative contraindications for HUTT, any severe obstruction like severe left ventricular outflow obstruction, critical mitral stenosis, proximal coronary artery disease, and severe cerebrovascular disease. All these will be relative contraindications for HUTT because of the risk involved. In the first phase of the test, the person lies in the supine position for 30 minutes. This is followed by a tilt phase of 20 minutes at an angle of 70 degrees. If fainting does not occur during the period, the tilt table is brought to the horizontal position for 10 minutes. After that, isoprenalin infusion, which can increase the heart rate and myocardial contractility, is infused at the starting dose and the drip is run for 10 minutes with the table tilted to 80 degrees. Still, if syncope does not occur within 10 minutes, the table is brought down to the horizontal position for 10 minutes. The test is repeated at 2 higher doses of isoprenalin with intervening 10 minutes in the horizontal position if needed. If no syncope occurs even with the higher doses of isoprenalin, the test is considered negative. Syncope can occur at any of the above stages with either bradycardia, hypotension or both. The first response is called cardioinhibitory, second as vasodepressor, and third as mixed variety. Strapping of the person to the table prevents a fall and injury if the person faints. There are some experts who feel that head-up tilt test is not useful and should be abolished. A change in the pattern of HUTT response with age has been described, with cardio-inhibitory response becoming less common with advancing age. This difference is thought to be due to the higher vagal activity in younger age, promoting more of cardio-inhibitory responses.